Thank you very much. So besides fancy therapy, fluid therapy, hemodynamic optimization, antibiotics remain the cornerstone of the treatment of septic patients, and antibiotics should be adequate and appropriate. This concept is a complex challenge for clinicians because, as you heard, there is a problem for the early identification of microorganisms. There's an increasing prevalence of multi-drug resistant pathogens, so you may prescribe the wrong drug regimen, and there is a change in pharmacokinetics of this drug that may alter the effectiveness of our drug regimen prescription. So optimized therapy means individualized drug prescription. So if we want to optimize it to get the optimal therapy, I think the first step is to give an early antibiotic therapy. I know that everyone has read this paper. One of the most downloaded papers from critical care medicine from Anand Kumar is retrospective analysis driven by students on 2,000 patients, where the authors show that the longer was the time from hypotension to antibiotics, the higher was probability of death, with a 7% increase of death for every half an hour. So we may criticize this paper because it's retrospective, but I think it underlines the concept of being early for those patients who look more severe, those who have an hypotension, and even underline the concept of delayed administration of therapy as a concern for effectiveness. Now, this data has been confirmed in other studies, but there are barriers to implement this strategy in your practice. Lead to the delayed recognition of sepsis, slow collection of the samples. In some countries, the drug is not available because it depends on the pharmacist. It may be dependent on the prescription of the ID physician. But I think the more important barriers are that if you give too many antibiotics, this could increase the cost, of course. When you look at the meta-analysis, early therapy, which means antibiotic within 1 hour, does not look so more effective than early within 6 hours, so which is the definition of early. And as you know, this concept of early therapy is not effective in less severe infection. If you have a pneumonia, you're at home, you don't need to take the antibiotics within 1 hour because this will not increase your risk of death, of course. And then there is the risk of delayed diagnosis. You may feed these patients have a sepsis, you give antibiotics very early, you say, okay, I'm done, I have my diagnosis, and finally it's a hemorrhagic shock. And finally, the risk of resistant strains. The more antibiotics you will give, the higher is the risk of get resistance in your hospitals. And then the concept is after giving early, at least for severe infection, you have to prescribe the appropriate therapy. Now, appropriate therapy means that you give a drug which is effective in vitro against the pathogens which is responsible for the infection. And these are only few examples, there are many of these, where appropriate initial therapy is at least associated with a better outcome when compared to inappropriate therapy. Inappropriate means you recognize the pathogen is insensitive and you change the prescription thereafter. Now, the concept of appropriate is related to the fact that you identify this microorganism, you test in the lab the sensitivity to the drug, and of course you will not be able to identify the microorganism before your lab will give you the results. But in most of these patients, at least the most severe ones, you will prescribe empirical therapy. In that case, of course, your choice will be depending on patient's history. Patients have made some travels, he had received some recent antibiotic therapy, this patient is immunosuppressed, or this might be dependent on your hospital ecology, or maybe community. As you know, if you are in India or some other countries, China, there are some very resistant strains which are already responsible for community-acquired infection. But even if you are very good in your clinical choice, there might be some errors, and of course, you don't want to prescribe the wrong antibiotics in the more severe patients. This is where technology could help us, at least in the future. You know that there is different techniques. The MALDI-TOF is one of them. MALDI-TOF is able to rapidly detect ESBL enterobacteriaceae or carbaphenemases producing strains within, let's say, 150 to 200 minutes, at least from road culture, which means that the delay from the analysis to the recognitions of the pathogens is very short within the concept of early therapy. Maybe in the future the FISH techniques, the PCR techniques, can give us more information about whether or not the pathogen is sensitive or resistant to commonly prescribed antibiotics. This would help us to identify resistant pathogens. Of course, increased cost, is not available everywhere. This is validated at least for blood culture. We don't know if it is effective even in other liquid, for example, BAL, but this is again something that could be implemented at least in very severe patients when you need an early diagnosis. After appropriate therapy, the concept, of course, that you may want to give a combination therapy, which is the reasons why I want to give a combination therapy. It's because combination therapy increases antimicrobial effectiveness, because when you give it empirically, it will widen the spectrum of activity. And if you know already the pathogens, for example, Pseudomonas, you want to have some in vitro synergy, at least in vitro, because as you know in humans, this concept of synergy has not been well validated. Of course, there are risks for combination therapy. You may increase toxicity, especially if you give an aminoglycoside, or you can select resistance. And you know that with the wide use of fluoroquinolones, we have a 30 to 40% resistant strains to quinolones in our hospitals. And if you look at meta-analysis or more recent trials where a monotherapy was compared to a combination therapy, results are not so outstanding. These are two recent examples of a study on severe sepsis and the second one of ventilator-associated pneumonia, where monotherapy was at least as effective as combination therapy. Of course, you can say these were heterogeneous population, these were not so severe patients. In some cases, the strain was so sensitive to the first drug that the second drug did not add any synergy. So there are a lot of criticism, but still looking at the randomized clinical trials that seems to drive all our clinical practice, there is no evidence suggesting combination therapy. I want to mention this paper, not because Anand Kumar is a friend of mine, because I think he reviewed the literature and he tried to understand in which context combination therapy could be effective. And what he did is that he did the meta-analysis of different trials looking at the combination therapy versus monotherapy. And what he underlined is that when the patient sees a critically ill, meaning it is in shock or it's a life-threatening infection, this is the situation where even in community-acquired pneumonia, combination therapy may be more effective than monotherapy. So again, not giving to any patients, but ask for early therapy, ask for appropriate therapy. In the most severe patients, there is an interest to give a combination therapy. Now, if you give it early, appropriate, and the combination therapy, still there might be some therapeutic failure. And this is the concept that I like, that if you want to optimize drug therapy, you need to give the right dose. Now, right dose, which means adequate therapy, in terms of pure microbiological data, means a dose that is able to produce adequate concentration to kill the bacteria. This is what you observe in this kind of in vitro experimental data. Increasing concentration, increasing bactericidal activity. Now, why standard regimens of antibiotics should not produce adequate drug concentration to treat our patients? First, because MIC of pathogens isolated in the ICU are higher than pathogens isolated outside the ICU. So the standard regimen could be effective for community-acquired infection, but not for hospital-acquired infection. And second, because there are some changes in the patient that may alter the concentration of the drug. These changes are due to our therapy, the fluid, increased cardiac index. This may some patients increase the renal flow, and for drugs that are eliminated by the kidney, in particular hydrophilic drugs, beta-lactams, they will increase drug clearance. And also, you have always observed this phenomenon of capillary leakage, this venous pooling, and then this will increase the distribution volume of the drug. Which are the consequences? If you compare drug concentration in blue with drug concentration in green, blue is a healthy patient, so less severe infection. Green is a critically ill patient. An increase of volume of distribution will reduce the peak concentration of the drug. Is it important? Yes. If you give an aminoglycoside, the peak concentration will drive the effectiveness of the drug. What happens if the clearance is increased? The time the drug concentration exceeds the MIC of the pathogens will be lower. Is it important? Yes. Beta-lactam's effectiveness depends on the time above the MIC. This is why we give 3-4 times a day. In other words, at least in the initial phase of therapy, because of these changes, you will have lower than expected concentration giving start on drug regimen. And if you consider also that we are treating pathogens with an increased MIC, of course the peak over the MIC concentration or the time of the MIC will be lower than expected. And again, this is true for the early phase, because my topic was initial therapy. The results will be in the 30 to 50% of patients a lower than expected drug concentration when you give the same regimen to a less severe patient. And you don't have to forget in some patients, characteristics like obesity, the use of extracorporeal therapies, burns, can further alter these PK parameters and can increase the percentage of patients with insufficient drug concentration. So how to optimize dosing? You have to fill in the volume of distribution. You have to give a higher than standard regimen. So this is the concept. The volume distribution is lower. You have to increase the loading dose. And the loading dose is extremely important to optimize drug concentration. This is independent of renal function. You give the loading dose according to patient's characteristics and not according to renal function. These are the two papers coming from Belgium, from 4 different ICU, where we measured drug concentration of beta-lactams and aminoglycosides in patients with severe sepsis and septic shock. We have observed that in terms of drug concentration, at only if you treat the less susceptible strains, like Pseudomonas aeruginosa, a large proportion of your patients will have insufficient drug concentration, which means that in terms of beta-lactams, if you want to optimize drug concentration, these data will be published soon. We did a simulation, we are doing the validation in real patients. You have to double the loading dose to obtain adequate drug concentration since the first administration. And the same for aminoglycosides. If you want to optimize the peak concentration to treat Pseudomonas, you have to give a higher drug regimen that's standard. You have to move from 15 to 25 to 30. And of course, if you want to optimize later doses, the first, the second, the third day, the first days of therapy, if you deal with beta-lactams and you have this increased clearance, you have to give it every 2, every 3 hours. It will increase the cost of therapy. This is why, if you want to optimize drug therapy in the initial phase, at least for beta-lactams, the concept of continuous infusion came out. It's the best and more elegant way to keep drug concentration above your threshold of MIC. Now, does it work? I will just mention this recent meta-analysis that take into account 2 studies from Australia and 1 study from Malaysia, where continuous infusion were associated with a lower hospital mortality when compared to standard regimens. You can criticize the approach because no one of these studies were really positive. There were a lot of differences between the population. And again, this is true for those patients who are not on renal replacement therapy, because in that case, drug accumulation will occur, and there will be much less patients with sufficient drug concentration. But at least this is the best that we have in the literature to support the use of a continuous infusion, and again in the most severe patients. So to conclude, when you deal with infection and you have to give antibiotics, I think you have to take into account patient situation. If a patient has an uncomplicated infection or a life-threatening, or you are treating a multi-drug resistant strains, your approach will not be the same. In terms of timing, you can give it early in the very severe infection and wait for a complete diagnostic process when the infection is not so severe. In terms of appropriateness, you can consider molecular diagnostic because you want to be appropriate since the first dose, while you can wait routine specimens in less severe infection. Should you use combination? I would say yes, but again, in severe infection, in patients who have a non-severe infection, the role of combination therapy is not so huge, and you may even deal with the increased risk of toxicity. And finally, in terms of dosing, you may use a standard regimen where you treat uncomplicated infection because there are no pharmacokinetic changes, and especially in case when you treat the very susceptible strains. But if you deal with severe sepsis, now it doesn't exist anymore, with sepsis and septic shock, and if you deal with difficult to treat pathogens, the use of higher loading doses, a continuous infusion of beta-lactams will at least optimize your drug concentration.